hearing by trying to simply state my frustration. It's the year 2015. We live in a complex, interconnected society with self-driving cars, wearable technology, and complex algorithms that can predict when a critical mechanical component is going to break. But our soldiers, sailors, airmen, and Marines who are making the transition from DoD to VA healthcare are literally told to print out hard copies of their medical records and then walk them to the VA. We have sent men to the moon and robots to Mars. I feel like we should be able to move one electronic file, no matter how big, no matter how old, from one computer system to another. I don't mean to understate the enormity of the challenge of integrating the two largest federal bureaucracies, but it is clear to me that our inability to integrate these two systems is a problem of leadership rather than technical feasibility. The story of the interoperable electronic health record starts in 1998 with the government computer-based Patient Record Initiative. Since then, I have counted 6 programs or other initiatives from 2002 to 2013 designed to increase the exchange of healthcare data between the VA and the DoD. In that time, we've had 3 presidents and 2 wars. And the members of our armed forces are still coming home to find that 2 decades was not long enough for these 2 departments to get together and develop a workable and fully interoperable electronic health record. While today's hearing could include a conversation laced with technical terminology, interoperability, mapping national data standards, graphical user interfaces, and health data domains, at its core, this is not a problem of technology. This is an issue of management. Why did these 2 departments abandon the Integrated Health Record Program? Cost effectiveness was the answer given after spending, according to the Interagency Program Office, $564 million on the Integrated Health Record. But continual failures to make deadlines and deliver on capabilities led to these 2 departments doing what they so often have done in the past, go their separate ways. The current plan for DoD and the VA to modernize their healthcare IT infrastructure in order to achieve full interoperability lacks metrics and goals. These are not issues of data standardization. This is Management 101. In FY 2014, the Department of Veterans Affairs spent $3.2 billion on outdated legacy technology, while the Department of Defense spent $24.3 billion. Over the summer, DoD awarded a $4.3 billion contract award to upgrade DoD's DIM-SUM program, which is DoD's program to modernize its health IT systems. But what concerns me are the statements by Mr. Frank Kendall, the Undersecretary of Defense for Acquisition, Technology, and Logistics, who downplayed the role of DIM-SUM in interoperability. Mr. Kendall made these 2 comments about DIM-SUM. Begin quote, "It's a big misconception out there that this software system we're buying is about interoperability, period. There is not a big interoperability problem with the VA and DoD today," end quote. This is the problem I keep coming back to. Does management understand the depth of the problem when it comes to interoperability? And let me say this right now, just to get it out of the way. The Joint Legacy Viewer, the JLV, is not real interoperability. And I hope that is not any one of y'all's answers today to any of our questions about interoperability. The ability to view patient data and the ability to access and use in real time patient data are 2 profoundly different things. Missed deadlines, cost overruns, and failures to deliver on expectations leave me with serious doubts about these 2 departments' ability to work towards this common goal. When can DoD and the VA actually implement their planned IT improvements? When can DoD and the VA modernize their systems? When can DoD and the VA achieve full interoperability? I'm looking forward to exploring these topics today. My colleagues and I recognize these are big challenges. Interoperability of health records is something the private sector is still struggling with. But if DoD and the VA get it right, they can be a model for the rest of the world. At the end of the day, when we cut through all the technical jargon, the myriad of acronyms, and the countless PowerPoints on this topic, we have 2 very simple questions that must be answered. When will our men and women in uniform be able to walk across the street the day they are discharged from service to a VA medical facility and have their health record waiting for them? And who is in charge of making this happen? It's now my pleasure to recognize the ranking member of the Subcommittee on Information Technology, Ms. Kelly from Illinois, for her opening statement.